The female reproductive system. The female reproductive system comprises the ovaries, oviducts, uterus, vagina, and external genitalia as well as the mammary glands. Before puberty, the germ cells of the ovary are in the resting stage. After the pituitary gland begins to release gonadotropic hormones, the reproductive system becomes activated, around 12 years of age, and menarche, the first menstruation, occurs. From then, the 28-day menstrual cycle continues for the entire reproductive life of the woman until menopause is reached. Ovary. Each ovary, 3 cm x 2 cm x 1 cm, is attached to the broad ligament of the uterus by the mesovarium mous germinal epithelium, which overlies the connective tissue capsule, the tunica albuginea. The ovary has an outer cortex and an inner medulla. The connective tissue stroma, interstitial compartment, of the cortex is populated by ovarian follicles and stromal, interstitial, cells that resemble fibroblasts and form the theca interna and externa of the ovarian follicles that house the primary oocyte. At fertilization, the sex of the embryo is determined by the presence or absence of the Y chromosome. If the Y chromosome is present, then the transcription factor of the SIDF gene, sex-determining region on the Y chromosome, the testis-determining factor, induces the development of testes. The absence of the sequel gene causes the default condition development of female gonads. Early in development, a pair of epithelially covered ridges, the gonadal ridges, forms, and epithelial cells from their covering migrate into the gonadal ridges to form primitive sex cords. By the 6th week after fertilization, primitive germ cells migrate from the yolk sac into the gonadal ridges, induce further development of the gonads, and continue to divide to form numerous germ cells. At this point, the male and female gonads are identical and are known as indifferent gonads. In a female, the primitive sex cords migrate into the medulla of the gonadal ridges and form clusters of cells that degenerate soon, to be replaced by connective tissue. During the 7th week, other cells of the epithelial cover migrate into the cortex to form the cortical sex cords. During the 4th month, these cortical sex cords dissociate, and their cells surround primitive germ cells, become known as follicular cells, although follicular cells may also arise from the germinal epithelium, and the primitive germ cells become oogonia. By the end of the 5th month of fetal life, each ovarian cortex houses at least 3 million oogonia, but only 500,000 become surrounded by follicular cells. The others degenerate. The remaining oogonia enter the first meiotic division and become known as primary oocytes. Each primary oocyte with its surrounding follicular cells is known as a surrounding follicular cells is known as a primordial follicle. Follicular cells surrounding the primary oocyte secrete meiosis-preventing factor, which arrests the primary oocyte in the diplotene stage of meiosis I until just before the oocyte is ovulated. In the first 10 years of life, 2/3 of the primordial follicles undergo atresia. The remaining primary oocytes may continue to be in this arrested meiotic state until puberty or for the next 30 to 40 years. During development, in response to estrogens, the fallopian tubes, body, and cervix of the uterus, and upper portion of the vagina are formed by the fusion of the right and left Müllerian, parmesanefric, ducts. Around the 9th week after fertilization, the wall between the two fused ducts disintegrates, forming a single lumen. Occasionally, this fusion does not occur, and the individual has two, smaller uteri, known as uterus didelphys, and two cervices and two separate vaginas, each opening into its own uterus. More commonly, the wall between the two Müllerian ducts remains intact, but the lumina of the two horns of the uterus open into a shared, single vagina. This condition is known as uterus bicornis. The WNT4 gene regulates genes that function in the development of the ovaries by suppressing the gene responsible for testis development, SOX9, and activating a series of genes, including DAX1, a member of the nuclear hormone receptor family that directs the development of the ovaries. Although it has not been shown in humans, In mice DAX1 regulates a gene that codes for a part of the TATA box binding protein for RNA polymerase. In the absence of this protein, the mice cannot form ovaries. During a woman's reproductive life, she ovulates every 28 days and releases about 450 oocytes. Since the female embryo does not manufacture testosterone or anti-Müllerian hormone, the mesonephric duct degenerates. Estrogens formed by the female embryo induce the Müllerian ducts, parmesonephric ducts, to form the fallopian tubes, body and cervix of the uterus, and part of the vagina. Ovarian follicles. There are two categories of ovarian follicles: primordial, non-growing, follicles and growing follicles. The latter have four stages: unilaminar primary follicle, multilaminar primary follicle, secondary, antral, follicle, and Graphian, mature, follicle, Fig 20.2 and Table 20.1. Of these, secondary and Graphian follicles, but not the dominant follicle, require follicle-stimulating hormone, FSH, for development, whereas primordial and both types of primary follicles develop because of unknown local factors possibly manufactured by the follicular cells. During any one particular menstrual cycle, approximately 50 primordial follicles begin to develop. However, they begin their development at various times during the cycle, so that follicles at different stages of development are present in the ovary. The primordial, non-growing, follicle, the smallest and least mature of the follicles, is a spherical cluster of cells composed of a small, 25 heme diameter, primary oocyte, in prophase of meiosis I, surrounded by a single layer of flat follicular cells that adhere to each other by desmosomes. The follicle is enveloped by a basal lamina that isolates the follicle from the connective tissue stroma. Unilaminar primary follicles are composed of a primary oocyte, 100 to 150 km in diameter, whose nucleus is large and vesicular appearing, and referred to as the germinal vesicle, surrounded by a single layer of cuboidal follicular cells, see Fig 20.2 and Table 21. Multilaminar primary follicles resemble the unilaminar primary follicles except that mitotic activity of the follicular cells resulted in the formation of several layers of follicular cells, granulosa cells, around the oocyte. Additionally, a layer of amorphous material, the zona pellucida, composed of the glycoproteins ZP and ZP is formed by and surrounds the primary oocyte. Not only do filopodia of thegroilosa cells invade the zona pellucid, contact the oocyte cell membrane, and form gap junctions with the primary oocyte, but the granulosa cells also form gap junctions with each other. The stroma surrounding the granulosa cells but separated from them by the basal lamina, become reorganized to form an inner vascularized cellular layer and an outer fibrous layer, known as the theca interna and the theca externa, see Fig 20.2 and Table 21. The cells of the theca interna display membrane-bound luteinizing hormone, LH, receptors, and because they synthesize and release the male hormone androstenedione, they have the fine structural features of cells that manufacture steroid hormones. The released androstenedione crosses the basal lamina to enter the granulosa cells where the hormone is converted to estradiol, an estrogen, by the enzyme aromatase. Secondary, antral, follicles are similar to multilaminar primary follicles except that the primary oocytes are larger, 200 km in diameter, see Fig 20.2 and Table 20.1, the granulosa cell layer becomes thicker, and fluid-filled spaces, called Exner bodies, form among them. The fluid, liquor folliculi, is extracellular fluid enriched with steroid-binding proteins derived from the granulosa cells, glycosaminoglycans, proteoglycans, and hormones such as progesterone, estradiol, inhibin, follistatin, folliculostatin, and activin. Activin is a hormone that induces basophils of the anterior pituitary to release LH and FSH. The continued development of the secondary follicle is FSH dependent. Graphian, mature, follicles are recognizable by their large size and by the fact that the liquor folliculi that appeared in the secondary follicle as small, isolated pools of fluid are combined into a single, large, spherical fluid-filled compartment, The antrum. The wall of the antrum is composed of several layers of follicular cells, called the membrana granulosa, and at one point another cluster of granulosa cells, the cumulus oophorus, juts into the antrum, resembling Denmark jutting into the North Sea. The cumulus resembles a popsicle in that its stalk, arising from the membrana granulosa, is cylindrical and its expanded free end is spherical. The center of the free end houses the primary oocyte, surrounded by numerous layers of granulosa cells, the innermost layer of which, bordering the zona pellucida, is known as the corona radiata. Two different types of granulosa cells may be distinguished: cells forming the wall of the antrum, known as membrana granulosa cells, and cells of the cumulus oophorus, known as cumulus granulosa cells. The theca interna and theca externa continue to develop into thicker layers, see Fig 20.2 and Table 20.1. The dominant follicle refers to one Graham follicle that continues to develop, becomes FSH independent, and produces the hormone inhibin, which stems the release of FSH by the anterior pituitary, causing the degeneration, or atresia, of the other developing follicles. Usually, only the dominant follicle discharges its oocyte in ovulation. Ovulation. Ovulation occurs on the 14th day before menstruation and is a function of decreased FSH and a sudden surge of LH levels in the blood. These hormonal changes are due to the elevated levels of estrogen produced by the Graafian and secondary follicles, Figs 20.3 and 20.4. FSH-dependent follicles that have been progressing through development no longer have access to FSH, they degenerate and are known as atretic follicles. The surge in LH levels is responsible for the following events: blood flow to the ovaries is increased, leading to edema formation within the theca externa and the release of collagenase, histamine, and prostaglandin in the vicinity of the dominant follicle. The membrana granulosa of the dominant follicle undergoes proteolysis owing to the presence of LH-induced plasmin formation so that the dominant follicle can release its oocyte. Follicular cells manufacture and release meiosis-inducing substance, which stimulates the completion of the first meiotic division of the dominant follicle's primary oocyte, forming the secondary oocyte and the first polar body. The secondary oocyte begins its second meiotic division but cannot progress beyond metaphase. The granulosa cells continue to synthesize glycosaminoglycans and proteoglycans, resulting in continued accumulation of water and increasing the size of the dominant follicle, which increases its pressure on the tunica albuginea of the ovary, cutting off the blood supply at the place of greatest pressure. This avascular region of the ovary's capsule, known as the stigma, undergoes necrosis and, in conjunction with the proteolysis of the membrane granulosa in its vicinity, forms a channel leading from the lumen of the antrum to the peritoneal cavity. The secondary oocyte, surrounded by the corona radiata and accompanied by the first polar body, leaves the ovary, a process known as ovulation, and, normally, enters the infundibulum of the fallopian tube, oviduct. The remnant of the dominant follicle is converted into the corpus luteum, see Fig 20.3. Corpus luteum and corpus albicans. When ovulation occurs, the remnant of the dominant Graafian follicle accumulates a little blood from the damaged blood vessels in the area, collapses on itself, and is known as the corpus hemorrhagicum. Within a couple of days, the blood is resorbed by macrophages, and, owing to the influence of LH, this structure is converted into a temporary endocrine gland, the corpus luteum, see Fig 20.3. The corpus luteum comprises two principal cell types. 80% are granulosa lutein cells, derived from granulosa cells, and 20% are theca lutein cells, derived from theca interna. The basement membrane between the former theca interna and theca externa disintegrates, permitting vascularization of the region of granulosa lutein cells. Granulosa lutein cells are the larger of the two, and they synthesize progesterone and convert androstenedione, an androgen, into estradiol, an estrogen. The peripherally located theca lutein cells synthesize progesterone, androstenedione, and some estrogens. The progesterone and estrogen secreted by the corpus luteum inhibit the basophils of the pituitary from releasing FSH and LH, The hormones necessary for the development of ovarian follicles and for the maintenance of the corpus luteum, see Fig 2.0.4. If there is no pregnancy, the corpus luteum begins to degenerate and is referred to as the corpus luteum of menstruation. In the event of pregnancy, the forming placenta, but initially the trophoblasts of the developing embryo, releases human chorionic gonadotropin, HCG, that causes the corpus luteum to enlarge and sustains it for approximately 3 months, during which time it is referred to as the corpus luteum of pregnancy. After that time, the corpus luteum is no longer required because the placenta takes over the production of the hormones necessary to maintain the pregnancy, but it remains functional for several months. Eventually, the corpus luteum, of menstruation and of pregnancy, becomes smaller because of luteolysis, regression, and invading fibroblasts manufacture type I collagen fibers to transform the corpus luteum into a corpus albicans, a fibrous connective tissue that continues to be resorbed until it becomes just a scar on the surface of the ovary. Luteolysis is initiated by hypoxia due to reduced blood flow, which causes the arrival of T cells whose product, interferon Y, is responsible for macrophage recruitment. Macrophages release tumor necrosis factor D, which drives cells of the corpus luteum into apoptosis. Oviducts, fallopian tubes. Each oviduct is a narrow tubule that is open at both ends at its free, peritoneal end, where it approaches the ovary, and at its other end, where it attaches to and pierces the wall of the body of the uterus. The oviduct has 4 well-defined regions, recognizable by features specific to each region, Fig 20.5. The infundibulum is the free end of the oviduct, and its fimbriae press against the ovary during ovulation to trap the secondary oocyte, its attendant follicular cells, and the first polar body. The ampulla is the enlarged continuation of the infundibulum, normally the site of fertilization. The intramural region of the oviduct pierces the wall and opens into the lumen of the uterus. The isthmus is the narrow region between the intramural region and the ampulla. The oviduct has 3 layers: the inner mucosa, the middle muscularis, and the outer serosa, absent in the intramural region. The mucosa of the oviduct is highly folded, making its lumen very convoluted. It has a simple columnar epithelial lining, composed of PEG cells and ciliated columnar cells. PEG cells are columnar, non-ciliated cells. They secrete a fluid that not only is nutrient-rich, but also contains factors necessary for the capacitation of spermatozoa. Without these factors, spermatozoa are unable to fertilize the secondary oocyte. The nutrient-rich fluid nourishes not only the developing embryo as it travels along the oviduct, but also the spermatozoa. Ciliated cells are also columnar in shape and possess numerous cilia that propel the fertilized ovum toward the uterus. The lamina propria is composed of a vascular, dense, collagenous connective tissue surrounded by the muscularis, composed of smooth muscle and arranged in a poorly defined inner circular and an outer longitudinal layer. Except for the intramural region, the muscularis is covered by a serosa. Uterus. The uterus is a very muscular organ that houses the developing embryo and fetus until parturition. It is 7x 4x 2.5 cm and is composed of 3 regions: the body, fundus, and cervix, see Fig 20.5. The wall of the uterus has 3 layers: the endometrium, myometrium, and serosa or adventitia. The endometrium forms the mucosa of the uterus and is composed of a simple columnar epithelium with non-ciliated secretory cells and ciliated cells that cover the vascular connective tissue housing fibroblasts, decidual cells, and branched, tubular uterine glands. The endometrium has 2 layers, the thicker outer functionalis layer that is sloughed off during menstruation and the deeper basal layer that is conserved during menstruation and whose tissue is occupied by the base of the uterine glands. The basal layer is vascularized by the straight arteries, whereas the functionalis layer is served by the helical arteries. Both vessels arise from the arcuate arteries of the myometrium. The myometrium consists of smooth muscle arranged in 3 layers: innermost and outermost longitudinal layers and a middle circular layer. The middle circular layer is highly vascularized by the arcuate arteries and is often named the stratum vasculare. The muscle layers are replaced at the cervix by dense fibroelastic connective tissue. The size and number of the myometrial smooth muscle cells are directly affected by blood estrogen levels. The higher the estrogen levels, the larger and more numerous the smooth muscle cells. In the absence of estrogens, the smooth muscle cells of the uterus atrophy. During pregnancy, the opposite occurs, there is a hypertrophy and a hyperplasia of uterine smooth muscle cells. At parturition, corticotropic hormone induces the uterine smooth muscle cells and the cells of the membrane surrounding the fetus to release prostaglandins, which, in conjunction with oxytocin from the neurohypophysis, cause the myometrium to undergo contractions to expel the fetus. Continued release of oxytocin causes contraction of the uterine blood vessels to minimize blood loss that would otherwise result from the detachment of the placenta from the lining of the uterus. Much of the uterus is covered by a serosa except where the uterus adheres to the urinary bladder. In that region, there is an adventitia covering the uterus. The cervix is a highly fibrous structure that protrudes into the vagina as the terminus of the uterus. Its lumen is lined by a simple columnar epithelium composed of mucus-secreting cells. Where it enters the vagina, it is covered by a stratified squamous non-keratinized epithelium. The subepithelial connective tissue of the cervix houses mucus-secreting cervical glands whose secretion can either facilitate the entry of spermatozoa as during ovulation or form a thick mucus plug as during pregnancy to prevent the entry of spermatozoa into the lumen of the uterus. The change in consistency of the mucus produced by these glands is controlled by the blood level of progesterone. Acute endometritis inflammation of the endometrium is most frequently caused by Staphylococcus aureus or Streptococcus infection. Infection occurs if a portion of the placenta is retained, or if an abortion procedure was compromised. Other possible causes include instrumentation and even normal delivery. The patient presents with high fever and a vaginal discharge that contains pus. With antibiotic therapy, the condition resolves in about 14 days. The Pap smear technique, Pap smear, is a diagnostic method. Vaginal aspirates or cervical scrapes are obtained, the specimens are prepared for histologic observations, and the slides are examined microscopically for the presence of cells exhibiting anaplasia, dysplasia, and carcinoma. The Pap smear is a very inexpensive tool that should be performed annually for sexually active women and by 21 years of age in non-sexually active women. New guidelines have been proposed that decrease the frequency of Pap smears in women older than 30 years who have not had abnormal cells 3 years in succession. This procedure has saved countless lives by early detection of precancerous and cancerous transformations that would have resulted in serious malignancies of the cervix. Annually, about 55 million Pap smears are done in the United States, and 6% of these display some abnormality requiring the attention of a physician. Albuginea, which is inflammation of the oviduct, is also referred to as pelvic inflammatory disease, although pelvic inflammatory disease is an infection that involves any pelvic organ, not just the oviducts. Salpingitis is usually a sexually transmitted bacterial infection that begins in the vagina and spreads into the cervix and uterus. From there it spreads to the oviducts. Rarely, it is caused by the insertion of an intrauterine device. The condition is manifested by the common symptoms of pain in the lower abdomen that is exacerbated by sexual intercourse and during vaginal examination, fever, frequent urination, and a burning sensation during urination, and occasional nausea and vomiting. Diagnosis may involve a simple cervical swab that is cultured for bacterial growth or a laparoscopic examination of the uterus, oviducts, and ovaries. Antibiotic therapy normally alleviates salpingitis within 1 week. Frequently, the patient's sexual partner is also placed on antibiotic treatment. Menstrual cycle. The menstrual cycle is normally 28 days long and is divided into 3 continuous phases: menstrual phase, proliferative, follicular, phase, and secretory, luteal, phase. The cycle occurs when the woman is not pregnant. The menstrual cycle is interrupted in the case of pregnancy. The menstrual phase is about 3 to 4 days long. It begins with the onset of menses, vaginal bleeding, and is the result of reduced blood levels of estrogens and progesterone that cause initially sporadic, followed within 24 to 48 hours by continuous, constriction of the helical arteries, Figs 20.6 and 20.7. The lack of blood supply to the functionalis layer causes necrosis and, as the helical arteries rupture, subsequent plowing of the functionalis layer. The basal layer continues to receive a blood supply from the straight arteries and, although stripped of its epithelial cover, remains healthy. Epithelial cells of the base of the uterine glands begin the re-epithelialization of the denuded surface. The proliferative, follicular, phase, about 10 days long, begins at the end of menses and lasts until ovulation. This phase is characterized by the re-epithelialization of the denuded surface, rebuilding of the thickness of the endometrium and its helical arteries, and restoration of the glands, so that the functionalis layer is rebuilt until it becomes about 2 to 3 mm thick, see Fig 20.6. By the time of ovulation, the glands, although not coiled, start to accumulate glycogen in their cells. The helical arteries are just beginning to twist into a tight helix and have reached about 2/3 of the way into the functionalis layer. Just before ovulation, FSH, LH, and estrogen blood levels peak, see Fig 20.7. The secretory, luteal, phase, about 2 weeks long, starts after ovulation and ends when menses begins. During this phase, the glands of the endometrium become highly coiled, the helical vessels reach all the way to the epithelially covered aspect of the functionalis layer, which has become about 5 mm thick, and the lumina of the endometrial glands are filled with their secretory product, see Fig 20.6. By the 20th day of the menstrual cycle, the blood progesterone level has peaked, and the estrogen level is also quite high, although not at the high level it was during the proliferative phase, see Fig 20.7. The helical arteries become surrounded by cells of the stroma that enlarge and become transformed into decidual cells, decidual reaction, that store glycogen and lipids anticipating implantation of the embryo. Decidual cell function in anticipating and during the process of implantation is discussed subsequently in the section on implantation. Fertilization, when the secondary oocyte, its follicular cells, and the first polar body are released from the dominant Graafian follicle, they enter the fimbriated infundibulum of the oviduct and are transported by the muscular action of the oviduct muscularis and by the concerted actions of the cilia of the ciliated columnar cells of the oviduct, Fig 20.8. If spermatozoa have been introduced into the woman's reproductive tract, have undergone maturation in the epididymis and capacitation in the isthmus, and arrived at the ampulla of the oviduct, the sperm begins to press its way between the cells of the corona radiata to contact the zona pellucida. When ZP receptors in the cell membrane of the sperm bind ZP in the zona pellucida, the sperm undergoes the acrosomal reaction, releasing the enzymes present in the sperm's acrosome, mostly acrosin, allowing the sperm to penetrate the zona pellucida and to contact the oocyte plasma membrane. This contact induces the oocyte to release its lysosomal enzyme, which modifies the zona pellucida, the zona reaction, and makes the zona impermeable to other spermatozoa. The cell membrane of the sperm possesses fertilin that interacts with integrins and CD9 of the oocyte plasma membrane, permitting fusion to occur between the two membranes. The sperm enters the oocyte, a process known as fertilization. The oocyte then undergoes cortical reaction, preventing additional sperm from entering the oocyte. Resumes its second meiotic division, forming the ovum and the diminutive second polar body. Reforms its haploid nucleus, the female pronucleus, which moves toward the sperm's haploid nucleus, male pronucleus. The two pronuclei duplicate their DNA, and the nuclear membranes of both pronuclei break down. The spindle apparatus that forms as the centrioles migrate to opposite poles of the ovum is now a diploid cell, known as the zygote. The zygote undergoes mitosis, known as cleavage, and the resulting cells migrate along the oviduct toward the uterus, see Fig 20.8, and continue to divide, forming a cluster of cells known as the morula. If the oocyte is not fertilized, it degenerates within 24 hours. Implantation. As the morula travels along the oviduct, it is still surrounded by the zona pellucida, and its cells, known as blastomers, continue to divide. About 4 to 5 days after fertilization, the morula reaches the uterus, Fig 20.9. Uterine fluid penetrates the zona pellucida and rearranges the cells of the morula to form the blastocyst, whose lumen, the blastocele, contains uterine fluid and a small cluster of cells, the embryoblasts, inner cell mass. The peripheral cells that form the wall of the blastocyst are known as trophoblasts, see Fig 20.9. The zona pellucida disintegrates, and the trophoblasts express L-selectins and integrins on their surfaces, which contact receptors of the uterine epithelium, beginning the process of implantation. The endometrium, in the secretory, luteal, phase, is ready to nourish the embryo as it is embedding itself into the wall of the uterus. The cells of the embryoblasts form the embryo and the amnion. Trophoblasts form the embryonic portion of the placenta and induce the uterine endometrium to form the placenta's maternal portion. As the trophoblasts proliferate, they form an inner cytotrophoblast layer of vigorously dividing cells and an outer layer of non-mitotic syncytiotrophoblasts. As cells of the cytotrophoblasts divide, the newly formed cells are incorporated into the syncytiotrophoblast layer, which enlarges, becomes vacuolated forming interconnected lacunae, and penetrates the endometrial lining. By the end of the 11th day post-fertilization, the embryo and its layers have become embedded into the vascularized endometrium, Fig 20.10, see Fig 20.9. Placenta development. As the syncytiotrophoblasts continue to infiltrate the vascular endometrium, they penetrate the walls of many of the blood vessels and blood flows into the lacunae, supplying the early embryo with nourishment and oxygen. As the placenta develops, the cells of the trophoblasts form the chorion. With further development, the chorion forms the chorionic plate, from which the chorionic villi develop, see Fig 20.10. In response to the formation of the chorion, the endometrium of the uterus becomes known as the decidua. The decidua has three regions. Decidua basalis is the region of the decidua that becomes the maternal portion of the placenta. Decidua capsularis is the portion of the decidua located between the embryo and the lumen of the uterus. It does not contribute to the placenta and becomes known as the chorion lave. Decidua parietalis is the portion of the decidua located between the myometrium and the lumen of the uterus, the regions of the endometrium that are not in close association with the embryo or the placenta. The decidua basalis is invaded by the maternal vascular supply to form the maternal portion of the placenta, and the syncytiotrophoblasts and cytotrophoblasts of the chorionic plate respond by forming chorionic villi, known as the primary villi, of the chorion frondosum. As the cores of the primary villi become populated by mesenchymal cells and by embryonic blood vessels, the primary villi become known as secondary villi, see Fig 20.10. The cytotrophoblasts of the secondary villi are reduced in number as they become part of the expanding syncytium. As this is occurring, blood-filled lacunae develop in the decidua basalis, and the secondary villi protrude into these large, vascular spaces. The lacunae receive blood from and drain blood into maternal arterioles and venules. Some of the villi are anchored into the decidua basalis and are referred to as anchoring villi, whereas others are not anchored and are referred to as free villi. Capillary beds of the villi approximate the syncytiotrophoblasts, and nutrients and oxygen from the maternal blood penetrate the tissues of the villi to enter their capillary beds. Waste products and carbon dioxide leave the fetal capillaries to make their way from the villi into the lacunae to be taken away by the maternal blood. The fetal and maternal blood supplies do not come into contact with each other. The tissue interposed between the two blood supplies is known as the placental barrier, Table 20.2. Most small molecules can cross this barrier, but only a few macromolecules are capable of crossing it. Maternal antibodies are transported across the placenta by receptor-mediated endocytosis, and ions and glucose use active transport, ions, and facilitated diffusion, glucose. The syncytiotrophoblasts not only contribute to the formation of the placental barrier, but also secrete hCG, to maintain the corpus luteum, estrogen, progesterone, chorionic thyrotropin, and chorionic somatomammotropin. Prostaglandins and prolactin are synthesized by the decidual cells of the decidual stroma. Tables show components of the placental barrier: 1 fetal capillary endothelium, 2 basal lamina of fetal capillary, 3 basal lamina of cytotrophoblast, 4 syncytiotrophoblasts. Vagina and external genitalia: the vagina, Fig 20.11, an 8 to 9 cm long, 3-layered fibromuscular sheath located between the vestibule and the uterus, is composed of the mucosa, lined by a stratified squamous non-keratinized epithelium whose cells possess estrogen receptors, which, when occupied, induce these cells to form and store glycogen. The glycogen released into the vaginal lumen is metabolized by the indigenous bacterial flora to produce lactic acid, and by reducing the vaginal pH, it protects the vagina from pathogenic bacteria. Lamina propria, a highly vascular fibroelastic connective tissue richly endowed with lymphocytes and neutrophils. During sexual arousal, capillaries release plasma that diffuses into the lumen and combines with the cervical secretions to assist in lubricating the vaginal wall. Smooth muscle cells of the muscularis, which are longitudinally arranged, intermingled with some circularly oriented fibers. The external orifice of the vagina possesses circularly arrayed smooth muscle fibers that form a sphincter. Adventitia, a dense fibroelastic connective tissue possessing a well-developed venous plexus and an abundance of sympathetic nerve fibers that originate from the pelvic splanchnic nerves. The hymen, a thin connective tissue sheath covered on both sides by an epithelium, which restricts the vaginal opening in virgins. External genitalia: the external genitalia, vulva, consist of the labia majora, the homologue of the male scrotum, a pair of fat padded folds of skin, well endowed with sweat and sebaceous glands. The internal aspect is hairless, whereas the external aspect is covered with pubic hair, see Fig 20.11. Labia minora, couched between the labia majora, a pair of smaller folds of hairless skin whose connective tissue core is well innervat and richly vascularized, see Fig 20.11. Space between the two labia minora, known as the vestibule. It is moistened by minor vestibular glands located in its walls and by the glands of Bartholin. Both the vagina and the urethra open into the vestibule, see Fig 20.11. Two labia minora meet each other superiorly to form the prepuce over the small glands clitorides, the external aspect of the small clitoris, which is the homologue of the penis, see Fig 20.11. The two erectile bodies that compose the clitoris have a rich neurovascular supply and are highly sensitive to sexual stimulation. Mammary glands: the male and female mammary glands are identical until puberty, when ovarian progesterone and estrogens induce the further development of the female breasts by the appearance of terminal ductules and lobules, Fig 20.12. The female mammary glands increase in size by accumulating adipose tissue and connective tissue proper until approximately 20 years of age. During pregnancy, estrogens and progesterone are produced by the placenta and prolactin from the anterior pituitary and glucocorticoids and somatotropin, which induce additional development to prepare the mammary glands for the production of milk to nourish the newborn. After parturition, the estrogens and progesterone originate from the ovaries. The mammary gland, a compound tubuloalveolar gland, is composed of 15 to 20 lobes, where the dilated portion of the lactiferous duct of each lobe, known as the lactiferous sinus, narrows as it passes through and opens at the surface of the nipple. The lactiferous duct and sinus are lined by a stratified cuboidal epithelium, and the smaller ducts are lined by a simple cuboidal epithelium. All of the ducts are surrounded by some myoepithelial cells that are ensconced between the basal lamina and the duct cells. The mammary glands of postpubertal women are in the resting, inactive, state, unless the woman is pregnant, and then they are said to be in the lactating, active, state. The resting glands have a small clump of cells, known as alveolar buds, at the end of the lactiferous ducts and their smaller branches. Under the influence of progesterone, the alveolar buds develop further, and during pregnancy the additional stimulation provided by placental estrogens and lactogens induces the formation of alveoli that produce colostrum, a thick protein-rich and immunoglobulin-rich secretion, and after a few days postpartum, maternal prolactin and estrogens induce the formation of milk. The formation of milk is continuous, and its release for the suckling infant, the milk ejection reflex, is induced by oxytocin from the posterior pituitary.